Good morning and welcome to this webinar on shock and fluid balance, or fluid balance and shock. My name is Rachel Pascoe. I am hoping that you're all familiar with the webinar process, so if you do want to ask any questions or if you want to make any comments, please do so, and I'll try and answer them as we go along. And I'll get started in a moment. Is everybody able to hear me? I'll wait for some responses. Lovely, lots of responses coming through. Thank you very much. Great. Okay, I will just get rid of some of these responses now, otherwise my inbox will be completely full. Lovely. Well, welcome to this webinar on shock and fluid balance. Hopefully it will answer some questions or keep you, make you aware of what's required for certainly Janine, who I'm not sure if you've started Janine yet or whether you're still on your first scenario, but the lady who goes to theatre, and also will allow you to think about some issues related to shock and fluid balance. So let's get started. And as I said, please do ask some questions as we go along if you need to. Okay, so I'll start off by thinking about fluid balance and the fluid balance that's in the body, and what's the function of the body fluids that we've got. Firstly, what am I talking about when I talk about body fluids? Anybody got any ideas about what I'm talking about? Oh, gone forward. What am I talking about when I talk about fluids? Okay, I've got some interesting answers. Yes, I'm talking about interstitial fluid. I'm definitely talking about that. I'm talking about everything in the body. So somebody's mentioned blood, plasma, water, mucus. I'm talking about everything. I'm not necessarily, I am talking also about waste products. So somebody's mentioned urine and vomit. But what I'm mainly talking about when I talk about the body fluids is the stuff that's meant to be there. And when I talk about the stuff that's meant to be there, I am talking about blood, I'm talking about plasma, I'm talking about anything that's inside the cells. I'm also talking about anything that's inside the body systems. I'm not necessarily talking about things that might be in the gut, so your fluid and food intake, and I'm not necessarily talking about vomit and urine, because those are considered to be the waste products of all of our body functions. So I'm mainly talking about the stuff, for want of a better word, that is travelling around the body, transporting, as it says there, oxygen, carbon dioxide, nutrients, electrolytes, hormones, cells, waste and heat. So it's the fluids that are travelling around the body and our delivery system. So all of the things that are inside our body, and they enable us to perform all of our body functions, such as our chemical reactions, such as our cell reactions, such as our cell generation. So how much fluid do we have in our body? Typical, and I'm looking at that 70 kilogram as being a typical male weight. A typical male has 42 litres of fluid, of which 60% is water, and a female has 35 litres of fluid in the body, of which 50% is inside the cells, so and water. So we're looking at quite a large volume, and that includes everything that we've mentioned there. So interstitial fluid, the list that I've previously cited: blood, interstitial fluids, central nervous fluid, all of those different collective fluid measurements. Changes to our body water can occur, and I've got a list of, sorry, I'm just having a few technical problems with my screen, which is why I'm, right, that's better. So we have our total body water that we've been talking about, including our blood and our fluid, and these change dependent on age, body type, sex, and health status. So what might we typically expect to happen to our amount of body fluid when we get older? Do you think it'll go up or down? Yeah, absolutely correct. We're saying, predominantly we're saying down. So as our body fluid gets, as our body gets older, our amount of body fluid goes down, and that's because most of our cells shrink in size for all sorts of reasons. Now, a couple of people have said up. Now, it's going to go up if our health status is affected, which is that last one on the list. So what kind of things might happen to the body? What kind of diseases might cause our total body water to go up? Anybody got any ideas? Yes, some forms of cancer can make our total body water go up, i.e. we can develop edema, and a lot of people are mentioning edema. Heart failure, the amount of actual fluid in our body won't necessarily change when we've got heart failure, and we'll talk about that a little bit later on when we talk about shock, because it's not necessarily in heart failure, it's not the amount that's changed, it's the location, and that's what we've got to think about when we talk about shock. Cellulitis, fluid retention for all sorts of different reasons. People are mentioning kidney failure. Absolutely, our kidneys are think about them in a way like our tap, our body's tap, because they turn on and turn off, altering what we need to keep in our body and what we need to get rid of. So if our kidneys aren't working properly, that can really affect the amount of fluid that we have on board. So different types of fluid retention. People are mentioning respiratory conditions, cellulitis, renal failure, absolutely right, heart failure, cancer and edema, all excellent answers, and that will change the amount of fluid that we have on board. So you mustn't complicate or mix up health status and age. So we've got somebody that's getting older, they might reduce their fluid, total body fluid, but if they have a compromised health status, they will definitely increase for some reasons, like, for example, as we've said, kidney failure. Somebody's mentioned pregnancy. Well, it does increase your total body fluid, up to even 40% increase in the total amount of water or body fluid that you have on board when you're pregnant. The midwives would slap my wrist because that's not considered a change in health status, because it's completely natural. So, but yes, absolutely, it will change the amount of body fluid that you have. So we've got changes because we're getting older, or and our patients might be getting older. We've got differences in body fluid because male or female, and we've got enormous shifts in body fluid because of different health statuses. So think about what can be happening in your body and why fluid levels are changing, because how you act and how you react to somebody's condition is going to be very much dependent on their fluid status. I've also mentioned body type there. Somebody who is larger might have a slightly higher level of body fluid than somebody who is very, very slim or very, very undernourished. So that can also change your amount of body fluid. So how much fluid is gained and lost per day? So drinking, approximately, we take in about 1,500 mils, approximately. Obviously, these are a rough estimate. We have about 700 mils taken in food. We have gaseous exchange happening constantly throughout the day, and there's about 200 mils of fluid gained. What's lost is we've got evaporation across the skin, perspiration, we've got expiration, i.e. your gaseous exchange, we've got feces, about 200 mils, and we've got 1,400 in urine, and that's approximate. So if we were in perfect fluid balance, that would we would equal what we put in to what we let out. Obviously, that can change enormously if we are, and people have mentioned health conditions. So, for example, somebody mentioned COPD as a health condition. Our oxygenation levels will be compromised. We might lose more because of expiration if we suffer from COPD. We might be perspiring more if we are having more respiratory effort. So any health condition, we can look at these amounts and say, how will that change? Have we drunk enough? Have we eaten enough? Are we hot and therefore perspiring more, i.e. have we got a pyrexia and are perspiring more? Have we got a gastrointestinal infection which is causing us to defecate more, i.e. we're going to lose more fluid through feces? Are we passing more urine for a number of reasons? Is our elderly patient suffering from a condition which means that they're on a diuretic, which means that their kidneys are fooled into passing more? So when we're looking at our fluid balance charts, and hopefully all of you have been in placement now where a fluid balance has been recorded, and if you haven't, I'm sure you will before the end of the first year, fluid balance charts are enormously important, and they're not always incredibly well filled out, but it's one of the things that we should do better. And if you look at an awful lot of research that's been done over the last 5 to 10 years about fluid balance charts, what they say is how significant they are and how important they are. So when we're looking at what's going in and what's going out with our patients, we need to be very aware of whether they're in fluid balance. So when we're talking about fluid balance, we're talking about having the right amount of fluid in the right place, containing the right solutions. And that's really important because, as we've already mentioned, with a number of those health conditions, that it's not necessarily about having the right amount of fluid, it's having the right amount of fluid in the right place. And if our fluid, for whatever reason, is in the wrong place, then that's when we can run into some trouble. And it also needs to be containing the right solutes. So it's got the right things in it, in the right place at the right time. And if we don't have the right amount of fluid in the right place at the right time, our body can go into shock. And hopefully you've all heard the term before. But let's explore exactly what we mean by shock. Oops, just jump forward a bit. There. So Shock affects all parts of the body. It can happen very quickly and it can also happen very slowly. And it is about always, all forms of shock are about a loss of circulating volume causing poor tissue perfusion. And that's very important. So it's a loss of circulating volume. It doesn't necessarily mean that that circulating volume has exited the body, because as we've already stated, shock is about it fluid not being in the right place at the right time. And if we've got a poor circulating volume, that's going to cause poor tissue perfusion. And poor tissue perfusion can cause death. If our tissues die because they are not well perfused, it doesn't matter which tissue we're talking about, it will die. So shock happens when we've got poor tissue perfusion. And we talk about the stages of shock. The first stage of shock is compensatory shock. And we talk about that as the fight and flight response. And many of you may have heard about that already. We then talk about progressive shock and irreversible shock. Now, progressive shock is what it sounds like. It's progressing, and irreversible shock is exactly what it says on the tin. It's irreversible. If we have allowed our patient to go into irreversible shock, there is very little at that stage that we can do as healthcare professionals. So what is so important is that we've got to recognise the signs and symptoms in the body of compensatory shock so that we can treat it and manage it appropriately so that the patient doesn't go through progressive shock and into irreversible shock. And as I said earlier, it doesn't necessarily happen slowly or rapidly. It depends on which type of shock we're talking about. So it can happen. We can go through compensatory shock, progressive shock, and arrive at irreversible shock in a matter of minutes. It can take a matter of days. And it rather depends on what type of shock we're talking about. Jumped to again. So we've talked about our stages of shock. Now we're going to talk about our classifications of shock. Classifications of shock come in three different types. First one, hypovolemic shock. Second one, cardiogenic shock. And third one, distributive or vasogenic shock. So we're going to talk a little bit about hypovolemic shock to start with. And this is the one that most people are aware of or may have heard of. So some of you may already heard of the term hypovolemic shock, and it's exactly what it says in the title, hypovolemic shock. So we've got a loss of volume, a dramatic loss of volume in the body. So up to 15 to 25% of our total body fluid volume is lost. And in hypovolemic shock, that tends to be that it has exited the body. So in hemorrhage or in trauma or surgical damage. And what that means is that the amount of body fluid has exited the body. So we've got a decreased blood volume. And that means that we've got a decreased amount of volume that is circulating around the system. Sorry, somebody's mentioned that their volume they've lost their volume. Has everybody lost volume? Okay. I think it might be just a problem with you. Okay. Hopefully it'll return in a minute. Okay, it seems to be an individual problem, so maybe just check your computer. So with hypovolemic shock, we're talking about a dramatic loss in blood volume. So that's the amount of it is circulating around the body has gone, which means that we've got a decreased amount of venous return. So the amount of volume that is coming back via the major veins in the body, and particularly the venous vena cava, is decreased, which means that we've got a decreased stroke volume. And the stroke volume is the amount of blood that leaves the heart every time the heart beats. So we call that the stroke volume. So that is the amount of blood that exits the heart, either into the pulmonary system or into the out of the heart via the aorta. So the stroke volume is decreased, which means that we've got a decreased cardiac output, and therefore decreased tissue perfusion. So that's hemorrhage. Any questions on that? No questions? Now, hypovolemic shock is probably the simplest type of shock that we talk about. So what do you think would be the best way to manage hypovolemic shock? So what are we going to do as nurses? Excellent answers, absolutely excellent. Yeah. Firstly, we've got to find out where the loss is happening. So we've got to control the blood loss. So stop the bleeding. So if it's because of a surgical intervention, or it's because somebody's had a traumatic injury, we've got to manage that traumatic injury and we've got to stop the blood. And then we've got to replace the blood volume with IV fluids in the first instance, and in the second instance probably a colloid or a blood substitute if we can't get a blood transfusion itself. So we're replacing the volume, we're managing the loss, and we're replacing the volume. And that's really key. And often we're talking, so if we were talking, for example, about somebody that had a traumatic injury to the leg, we would manage the traumatic injury and the blood loss in the periphery, and we would be filling the patient with IV fluids and possibly blood. We're not necessarily going to lie the patient flat, because if we lie the patient completely flat, we can put quite a lot of strain on the heart, because the heart is then having to pump everything uphill. So we'll probably nurse the patient in a prone position, i.e. their head is slightly elevated, but we will definitely have them on some sort of bed or trolley, and we will manage the patient in a prone position with IV fluids, probably give them some oxygen just to keep them comfortable, because if we've got a loss in blood volume, we've got a loss of oxygenated blood, so we want to maximise the amount of oxygenated blood that's going around the system, so we might help them out there. So a little bit of oxygen, definitely IV fluids, and manage the bleed. So if you understand, and I'll use this phrase quite often, and certainly when you get to the third year I'll use it a lot. If you understand what's going on in the body, you know how to manage them. So if the patient is losing volume because of a trauma or an injury, we're going to manage the patient by replacing that volume. So we understand the pathophysiology, we understand what's going wrong here, and we therefore know exactly how to effectively manage the patient that we're caring for. So our management in hypovolemic shock is always replacing the volume and managing the bleed. Okay. So we then go on to the next one, and then this is where it becomes a little bit more complicated. So we talk about cardiogenic shock. Cardiogenic shock is always, we're talking about the heart, the cardiac system. And we're talking about the heart's ability to pump is impaired for all sorts of different reasons. So it's not that the volume is gone anywhere, it's still there, but because the heart is not pumping effectively, then the stroke volume is reduced and the cardiac output is reduced. So the end result, in a way, is the same as hypovolemic shock, but it's for a completely different reason. So we've got a decreased stroke volume and a decreased cardiac output, but it's not because there's a loss of volume. Somebody's asked a very interesting question about blood pressure. What will typically, let's just go back a little bit, what will have typically happened to the blood pressure in hypovolemic shock? Brilliant. So you're predominantly telling me that it will go down, which is absolutely right. So we know about the diastolic and the systolic blood pressure. Diastolic is the measurement on top, and the systolic is the measurement underneath. So in hypovolemic shock, the systolic and the diastolic will both go down, and in hypovolemic shock, they will predominantly go down by about the same amount. So your diastolic will drop and your systolic will drop. And if you're having a severe episode of hypovolemia, your systolic blood pressure may drop below 100. So your systolic, the top measurement, and your diastolic, the bottom measurement. Systolic drops, diastolic drops in hypovolemic shock. So in cardiogenic shock, if we're talking about the heart's inability to pump effectively, what might happen to the blood pressure in cardiogenic shock? Okay, we've got a mixed response now. What's going to happen is, because the systolic blood pressure, the systolic measurement, which is your top measurement, is about your stroke volume and your cardiac output. So your systolic measurement will drop, and it could drop below 100. Your diastolic measurement, though, is about it gives you an indication of what? What's your diastolic blood pressure telling you about? Your diastolic blood pressure, does anybody know what your diastolic? Yes, it's about your venous return, absolutely right. So if you've got a poor tissue perfusion and you've got a poor cardiac output, your diastolic will also go down. Not necessarily as dramatically as it does in hypovolemic shock, but your blood pressure will still drop in cardiogenic shock. Now, I'll be asking these questions again when we talk about the distributive shock, because it's going to be a little bit different in distributive shock. So, we've got a drop in blood pressure. Systolic and diastolic have dropped significantly in hypovolemic shock. In cardiogenic shock, they've dropped again, but maybe not quite so dramatically, because the volume hasn't gone anywhere. It's just not being pumped effectively around the body. And we talk about coronary cardiogenic shock, and we talk about non-coronary cardiogenic shock. So when we're talking about coronary cardiogenic shock, what might we be referring to? We're referring to something that's actually happening inside the heart. So something's going wrong with the heart, and that typically might be what? So again, you're all coming up with some excellent responses. Yes, the valves might not be working properly. So we might have a mechanical problem in the heart itself. but typically we're talking about an MI, so a myocardial infarction. Part of the heart muscle has died because of a disruption in blood supply. We might also be talking about an electrical problem in the heart, such as AF, left ventricular failure, all of those different conditions that affect the heart itself. So something's going wrong with the heart itself. Can you see the questions? Right. No, I can't, as I'm not typing the answers, that may be why you can't see the questions themselves. Okay, I'll carry on. Right, so if we're talking about coronary cardiogenic shock, we're typically talking about something going wrong with the heart. So there is a disruption in the heart itself. So just check it. Although the blood pressure. So we've talked about the blood pressure a bit, but what we haven't talked about very much is the pulse. So one thing that's going to happen in hypovolemic shock, yes, the pulse is going to increase because the heart is trying to work and pump what's left of the volume round. And in coronary cardiogenic shock and non-coronary cardiogenic shock, yes, the pulse will also increase because what the heart is trying to do is to get what's left circulating, or to try and make up the difference because the pump's not working very well. So in coronary cardiogenic shock, we're talking about electrical disturbances. We might be talking about an MI. What sort of conditions might we be talking about if we're talking about non-coronary cardiogenic shock? So we're talking about the heart's inability to pump for a non-coronary reason. So what might have caused the heart's ability to pump to be impaired? Coming up with some very interesting answers here. Okay, so we've got, if we're talking about heart failure or anything to do with the heart, so a blockage in the heart or an impairment in the heart, then we're talking about coronary cardiogenic shock. If we're talking about a blockage or a problem that's outside the heart, then we're talking about non-coronary cardiogenic shock. And non-coronary cardiogenic shock tends to be things like, and people have mentioned these, a pulmonary embolism, an embolism of some description around the body, a DVT. So a DVT might not necessarily cause it. We've got also a AAA, which I'm hoping you mean an abdominal aortic aneurysm rather than the Automobile Association or something. People have mentioned traumatic injuries, people have mentioned pulmonary embolus. We can call a traumatic traumatic injury might be something like a cardiac tamponade. We might have all sorts of external factors which will affect the heart. People have also mentioned things like acidosis and chemical disruptions. Now, chemical reactions or chemical impairments will cause coronary cardiogenic shock because they will cause an electrical disturbance in the heart. So irregular heartbeats and so on, AF, all of those things that people have mentioned, they will be considered to be a coronary cardiogenic shock because they are affecting the heart itself. So anything that's affecting the heart itself, a blockage or an electrical disturbance or heart failure, that would be considered coronary cardiogenic shock. But if we talk about a pulmonary embolus or a blockage or a chemical or anything that's happened outside the heart, then we're going to be talking about non-coronary cardiogenic shock. People have also mentioned things like brain injuries and spinal injuries. That we're not talking about coronary cardiogenic shock when we're talking about those sort of injuries. We will talk about that would be considered to be distributive shock, and we'll cover that in a bit. So coronary cardiogenic shock is when the heart itself is impaired, and I've used examples like MIs or electrical disturbances such as AF. Non-coronary cardiogenic shock is going to be when something outside the heart, typically a pulmonary embolus, cardiac tamponade, or a blockage or a problem outside the heart has affected the heart's ability to pump, and therefore it is not pumping effectively. So we've mentioned a little bit about presentation. So the heartbeat will go up, the blood pressure will go down, not necessarily as dramatically as with hypovolemic shock, but it will go down because we've got a decreased stroke volume, a decreased cardiac output, and therefore we will have a decreased venous return. So what's our management going to be? How are we going to treat this patient who has got a coronary or a non-coronary cardiogenic shock? Great. Now, I'm really, really impressed that most of you have given me appropriate answers, i.e. go for the problem. We've got to manage the problem with this patient, haven't we? What we can't do, and we absolutely mustn't do, is overfill them. Now, we might give them a little bit of IV fluid, and we might, but we are not going to give them a blood transfusion, and we are not going to pump them full of fluids because the fluid hasn't gone anywhere. It is still in our circulating volume. We're just not moving it effectively. So if we give the heart more to deal with, we're going to cause more problems than solve them. So with a patient who's got cardiogenic shock and we've got their pulse going up and their blood pressure going down, our instant reaction is to think, oh, let's fill them, but we mustn't. We absolutely mustn't. If we put lots and lots of IV fluids or a blood transfusion into a patient who's in cardiogenic shock, we will kill them because the heart will fail. So what we've got to do is very carefully treat the problem. So if we've got a patient who's having a heart attack, i.e. an MI, we've got to manage that problem. So either through drugs or a physical repair, we've got to solve the problem. If it's an embolism, we've got to thrombolize it in some way, shape or form, whether it's through chemical means or mechanical means. So we might have to use pacemakers if it's an electrical problem, all sorts of different things that we might have to do to solve the problem and help the heart pump effectively. What we mustn't do is fill this patient up with more fluid, because if we fill them up with more fluid, then the heart will fail. So think very carefully about how we'd manage this patient. We might put a little bit of IV fluid up, tiny bit, just to keep them hydrated and just to make sure that we've got background IV access. But what we wouldn't do is whack in some fluids, for want of a better expression. Unlike with hypovolemic shock, where we had to push the volume in, we don't want to push the volume in this patient because we'll cause permanent problems. So our management will be some tentative IV access, but a management of the problem itself. So if they've got a cardiac tamponade, it might be putting in a chest drain. If they've got a pulmonary embolus, it will be thrombolysing that embolus, probably taking them to the cardiac catheter lab, probably doing an angiogram, angioplasty, that sort of thing. So it's a mechanical or chemical management of the problem itself, not filling the patient. Is cardiogenic shock? If we don't assess our patient properly, yes, it could be. So one thing that's really, really key is to assess our patient and ensure that we understand what's going on. So that's going to be about taking the appropriate measurements and doing an appropriate assessment so that we know what's going on with our patient. So if our patient presents to us with a high pulse and a low blood pressure, it doesn't necessarily mean that they need filling. It might mean that they need to, we need to manage the heart or the heart's ability to pump. Okay, any questions on that? A cardiac tamponade. A tamponade is where there has been some sort of traumatic injury to the lining of the heart, and it causes the space in between the heart muscle itself and the sac that the heart is placed in to fill up with blood, maybe, or fill up with fluid. So what happens is that the heart itself, the muscle, gets pushed aside. And a cardiac tamponade is something that happens, I wouldn't say often, and it's not common, but if, for example, you've got a young, fit, healthy person who's been in a car accident, for example, and they may have got a crush injury to their chest, if one of their ribs is broken and it has pierced part of the heart lining, it can cause the sac that the heart's in to fill with blood. So we often see cardiac tamponades in traumatic injuries or in crush injuries. And it's something that we have to be very aware of, because if you've got a patient who's come in from a trauma, like a car accident, and they've got a drop in pulse, and they've got a drop in blood pressure and a raise in pulse, you might think that they're bleeding from somewhere, but let's be very careful, because you don't know where they're bleeding from, and if they're bleeding into a space in the heart, as we've already said, it's going to be problematic if we start filling them. How is it drained? Literally, you put a drain into the sac in the heart, and it's usually done in theatre, and it's usually done either, well, it can be done by an angioplasty, or it can be done in theatre by placing a drain into the sac in the heart, very similar to a chest drain. Okay, so cardiogenic shock, non-coronary and coronary cardiogenic shock. Hopefully you're all happy with those two. So distributive shock. Distributive shock is, well, far more complicated in a way. And when we talk about distributive shock, we talk about three different types. We talk about septic shock, we talk about neurogenic shock, and we talk about anaphylactic shock. What we're talking about when we talk about septic shock is a patient in sepsis. And hopefully all of you have heard of that expression. So that's a patient who's got a systemic infection. Neurogenic shock is when, and people have mentioned that one already, when we've got a spinal or a brain injury, when we've got some sort of trauma to the central nervous system. And an anaphylactic shock is a severe allergic reaction. And what happens with all of these different types of shock is that the volume hasn't gone anywhere, it's shifted, it's moved, it's redistributed. So instead of being where it's meant to be, i.e. in terms of in blood volume or something, in terms of an anaphylactic shock, what typically happens? If you've got a nut allergy and you eat, you have, yes, massive vasodilation, but you see visible swelling. If somebody's bitten by a bee, stung by a bee, and they have a bee allergy, the area swells. There is massive vasodilation. So the volume shifts to the affected area. And in terms of sepsis, that shift of fluid is out of the circulating volume, i.e. the blood volume, and into the interstitial spaces. Because when you're talking about septic shock, you're not talking about a specific location like you are maybe with anaphylaxis or with neurogenic shock. With sepsis, you're talking about a massive vasodilation, so movement of fluids out of the circulating volume and into the interstitial spaces. So again, the same as before, we've got a decreased venous return, we've got less volume coming back to the heart because it's gone elsewhere. We've got a decreased stroke volume, we've got a decreased cardiac output, and therefore we've got decreased tissue perfusion. But it's not left the body, it's moved. And so that's what's very important. So just in the same way as with coronary and non-coronary cardiogenic shock, we're not necessarily going to want to fill the patient with more fluids. We're going to have to move the fluid back to where it's meant to be. So what might typically happen to the blood pressure? No, the blood pressure is not going to go up. The blood pressure is still going to go down. But what will typically happen is that the diastolic and the systolic, the gap between the two will get much, much smaller. So we'll see a drop in blood pressure, but we will not see, we will see a shrinking of the gap. So the difference between our diastolic and our systolic measurement will be smaller. And that's because of the resistance that's happening around the body. So the diastolic measurement does not drop as significantly as the systolic measurement will. And so we can sometimes in septic shock and anaphylactic shock see a blood pressure of 90/70, which is an odd blood pressure to see. So what's our management going to be? Yes, absolutely. Absolutely correct with yours. You've got to treat the cause. Just like with cardiogenic shock and coronary and non-coronary cardiogenic shock, we've got to treat the cause. So in septic shock, we've got to treat the infection. So we've got to know that the infection and we've got to, so giving antibiotics, if that's going to be the correct way to treat the infection. With neurogenic shock, it's going to be a little bit more difficult, because how are we going to treat the cause of neurogenic shock? Neurogenic shock typically meaning a spinal injury. So we might therefore try and repair the injury, or we might drain. Neurogenic shock, an example of neurogenic shock as well as spinal injury, might be meningitis. So it might be a brain injury, a head injury which has caused a swelling in the fluid between the skull and the brain. We might, and so we might need to drain that fluid out. We might need to tap that fluid. In anaphylaxis, we need to treat the cause of the allergic reaction. So that might be, well, typically we use adrenaline to facilitate vasoconstriction, peripheral vasoconstriction, to try and bring the fluid back. So some people are responding by saying redistribute the fluid. Absolutely. So we're going to then use chemical means to try and persuade the body to send the fluid back into the circulating volume, and that might be through steroids. It might be through drug interventions, and it might be through diuretic interventions, but it will be about treating the cause and not necessarily filling the patient up. We will want IV access with anybody that's critically ill. We'll always want IV access. So some very slow fluids going through. But unlike with hypovolemic shock, we won't fill the patient up, because the volume, what's important to remember is the volume hasn't gone anywhere. It's just in the wrong place. I'm sorry that you don't understand the lecture without seeing the questions, but I can't publish the questions unless I type them up. And as I'm doing this session on my own, I can't type and talk at the same time. So, any questions about distributive shock? Yes, the pulse will go up. Typically, if in all types of shock, the pulse will go up, but it might also be so. Certainly, when we're listening to the pulse and we're taking the pulse, we might want to look at the tempo and so on. So it's not just about counting the number of beats, is it? It's about how those beats sound, how they're close together, are they regular, are they thready, all sorts of different things that we're looking for. So when we're assessing a patient who's in cardiogenic shock, we'll be very much listening to those subtle differences in the pulse. If a patient, but the pulse will go up. Rehab for neurogenic shock, absolutely, depending on what type of neurogenic shock it is. So if the patient's had spinal injury, then they will go to rehab, because they will have to manage whatever neurological deficits they're left with. What can cause neurogenic shock? Such as a traumatic injury to the spine, but also things like meningitis and so on. So those can be treated and effectively managed, and you wouldn't necessarily need any kind of rehab. Somebody asked the question, why isn't the Sepsis 6 used in England? Firstly, what do you understand by the Sepsis 6? Would be my second question. Right, the 6 primary interventions used to prevent deaths from septic shock, and yes, it is used in England, and it's predominantly cited in all critical care environments, and it's talking about how we firstly assess septic shock and then how we manage it, and the 6 interventions. Do you know what the 6 primary interventions are? Three diagnostic and 3 therapeutic. Yeah, okay. So what are the 3 diagnostic and the 3 therapeutic? Just waiting for, see if there's an answer coming. Absolutely. So we've got interventions that are going to assess and manage a patient who is in septic shock. Now, this has come from national guidelines which talk about the management of sepsis and the management of septic shock, and they talk about assessing the patient using arterial blood gases, blood cultures and blood tests, absolutely, and the treatment is, as you've said there, O2, IV antibiotics and IV fluids, which is what we've discussed, haven't we? If a patient's in septic shock, we need to give them oxygen, we need to treat the cause of the sepsis, possibly by antibiotics, and we need to give them some IV fluids. We need to be careful with the management of IV fluids, because what we don't want to do is overfill a patient who's in septic shock, because that can be problematic. And to help with the management of a patient in septic shock, we will closely monitor them, which will include our monitoring our fluid balances. We said right back at the beginning of the session how important it was to manage the input and the output so that we didn't overload a patient. So Sepsis 6 is a recommendation that came nationally, and I sort of am a bit concerned that you don't think it's used in the UK, because it's pretty much been a recommendation since 2011 when it was first published. So I would hope that everywhere you've gone clinically has knowledge of it, if not uses it, depending obviously depending on their environments, will depend on how often they require the management of a septic patient, but I would expect every acute and critical environment has knowledge and is adhering to it. And along with medical early warning scores and national early warning scores, it's used as an associated management principle. I've just had every patient I assess in the emergency department is assessed against sepsis 6 regardless of presentation. Well, your sepsis, when you're assessing a patient in an emergency department, regardless of presentation, I hope that you're not just looking for a patient who's septic, but the parameters in sepsis 6 are very close to those that are used in the national early warning scores. So it's about track and trigger of our patients, and that expression is used to ensure that the patients are being assessed in an appropriate manner and therefore treated quickly. We're looking at observations before we're looking at bloods. I think we're looking at them both simultaneously. You're going to take bloods and do observations. It's not necessarily one before the other. the toolkit from 2014 on sepsis 6 is from the Royal College of Physicians. The RCN commented on it, but the Royal College of Physicians wrote it. I would challenge the fact that it isn't being used. I would say that it is predominantly being used in critical and acute areas across England, Scotland and Wales, and we'll assess whether it's effective or not. So we've looked at the principles of hypovolemic shock. We've looked at the principles of coronary and cardiogenic shock. Another question that came through was, can you have coronary and non-coronary cardiogenic shock at the same time? There are a number of different types of shock that you can have happening simultaneously. You have to treat the primary cause of shock. And what can make a patient's condition and treatment and management far more complex is if they've got multiple pathologies. And as you're very well aware, I'm sure, very few patients that you come across out there in clinical practice only have one thing wrong with them. Most of our patients in clinical practice have multiple things wrong with them. And so it's going to be up to the assessment and the skills of the clinician and yourselves to decide what is the primary problem. A patient may come to you who's having an MI, but they may also be septic. There may be a patient coming to you who has pulmonary embolus, but also is suffering from hypovolemic shock. So how you manage your patient is going to be dependent on which is the primary cause of the problem. If the heart stops, the patient will die. So if a patient is suffering from coronary cardiogenic shock, that is your primary objective, to manage that particular problem. If they are then suffering from hypovolemic shock due to another reason, then you're going to have to treat that afterwards. So it's and when I say afterwards, it might be in the next minute, it might not be in the next hour. We often come across patients who have got pulmonary embolus, but are also septic. So it's a very fine line between managing your patient's sepsis and managing your patient's pulmonary embolus. So which do you do first and how do you manage them? So you might have multiple layers of complexity to your patients. It would be great if all of our patients just had one thing wrong with them at a time, and you could treat one thing after another in clear and easy sequence, but that's not actually how it happens in clinical practice. So yes, a patient can have coronary and non-coronary cardiogenic shock at the same time, but you're going to have to treat the one that's most significant. And that's going to be your assessment skills that are going to assist you in deciding what you do first. And that moves us nicely on to talking about patient assessment. Patient assessment is about taking observations, and all of you have become, hopefully, or are becoming very proficient in doing observations. When I say observations as part of patient assessment, I don't just mean taking their temperature and their pulse and their blood pressure and their respiratory rate. It's about observing the patient as a whole. So if you've got a patient who is septic, you're going to be looking at more than just their simple observations. There's going to be tissue perfusion, there's going to be peripheral perfusion. Are they cold? Are they warm to the touch? Their temperature might say one thing, the feel of their skin might say another. So it's about a whole set of observations in your patient assessment and a number of measurements, which might include blood gases, blood cultures, CVP measurements, urine outputs, your input and output measurements, so their full fluid balance. So all sorts of measurements might be listed. If we're talking about a patient with edema, we